All right, welcome everyone. In the next few minutes, we're going to cover some principles that could fundamentally change how you approach your very next pediatric case. We're going to dive into the essentials of pediatric regional anesthesia, focusing on what makes it so different and how to make sure your blocks are not just effective, but incredibly safe.
Okay, let's start right here. This sentence, it seems so simple, right? But it is literally the foundation for everything we're about to talk about. See, in pediatrics, size isn't just about using smaller needles or less drug. It dictates massive differences in their anatomy, their physiology, and how they handle our drugs. It demands a totally different way of thinking.
So, here's our game plan. We'll kick things off with the core concept. Kids are not just tiny adults. Then, we'll get into the key differences in their bodies and how they work. We'll cover the tricky parts of pharmacology and dosing, talk about why ultrasound is a game changer, and then wrap up with the absolute must-do safety practices. Okay, let's really dig into this first point. It's the most important concept to get right. You just can't take what you do in an adult and scale it down. A child's developing body presents unique challenges and some pretty serious risks that require a completely different mindset from the very start.
Now, this slide is fantastic because every single one of these points directly changes what you do at the bedside. You've got a spinal cord that ends lower, which means a much higher risk of direct needle trauma. Their bones are soft and cartilaginous, so you won't feel the same pops. The epidural fat is loose and watery, changing how your drug spreads. Their nerves aren't fully myelinated, making them super sensitive to local anesthetics. And, funnily enough, their immature system makes them way more stable than adults during a block.
All right, let's unpack these a bit more. It's one thing to know the differences, but it's another to really understand the why behind our pediatric-specific techniques.
So here's the bottom line. In an infant, your needle has a way higher chance of hitting the actual spinal cord if you're doing a lumbar approach. This is precisely why we avoid going above L3 for neuraxial blocks in these little guys, and it's a huge reason the caudal approach is such a workhorse in pediatric anesthesia.
And this is where the rubber meets the road, right? This stuff changes everything. You can't rely on the feel of the needle popping through a ligament. It might not happen. That loose, watery fat means your caudal block can spread way higher than you'd expect. But the cool part? That incomplete myelination means you can get an amazing block with weaker, more dilute concentrations of local, which is a massive safety win.
Okay, so here's some good news. This is one of the few times physiology is actually on our side in peds. You know how a spinal in an adult can make their blood pressure plummet? Well, kids just don't have that kind of sympathetic tone to lose, so you usually don't need to preload them with fluids or have pressors ready to go. They just stay stable. It's pretty great.
All right, let's switch gears to pharmacology. This is where things get subtle, but man, they are critically important for preventing what we all worry about, local anesthetic systemic toxicity, or LAST. So you've got this trifecta of things happening at once, but the big one, the one you really have to burn into your brain, is the decreased protein binding. It means for any dose you give, more of that drug is free and active in the bloodstream. That seriously increases the risk of toxicity. And while their body water content helps a bit at first, their immature liver means the drug hangs around for a long time. This makes continuous infusions and repeat doses a really delicate balancing act.
Okay, everyone, listen up. If you remember one thing about toxicity, let it be this. In an awake adult, you usually get warnings. They'll say, "My ears are ringing," or "I have a weird taste in my mouth." In an anesthetized kid, you get none of that. Their first sign of LAST might be a sudden seizure, a scary arrhythmia, or just straight-up cardiac arrest. You might get absolutely no warning at all.
And this is why you can't just relax once the patient hits the PACU. Because everything is slower in their little bodies, the peak drug concentration in their blood can be delayed, sometimes for up to 2 hours. This means they need close, careful monitoring long after the surgery is over. The danger isn't gone just because you're done.
You absolutely have to know these numbers. Calculate the dose based on weight, every single time. But please remember, these are maximums, not targets. The real rule is to always use the lowest possible dose that gets the job done. This is especially true for the little ones under 6 months old. They're at the highest risk.
Okay, so we've talked about all these anatomical curveballs and pharmacological risks. So the big question is, how do we actually do this stuff safely?
Well, the answer has totally revolutionized how we practice pediatric regional anesthesia. It's moved from being a neat gadget to the absolute standard of care.
Ultrasound is not just a helper anymore. For most peripheral nerve blocks, it is the way we do it. It lets us tackle all those challenges we just talked about head on. We can see the weird anatomy. We can avoid blood vessels in the pleura. And this is the real game changer. We can watch our local anesthetic spread in real time. This confirms we're in the right spot and lets us use the absolute minimum effective volume, which is our single best weapon against toxicity.
And this quote from the literature really sums it all up perfectly. Ultrasound isn't just about seeing better. It fundamentally makes our practice better. We use less drug, we poke the patient fewer times, and we get a better block. It's just safer and more effective. End of story.
All right, let's bring it all home with what might be the most important section, your non-negotiables, pre-flight checklist for safety. This is what you do every single time you perform a regional block on a child.
This one is simple. There are 0 exceptions. It doesn't matter if it's a simple caudal or a complex plexus block, it has to be done in a place where you have everything you need to handle a full-blown emergency. That means monitors, airway gear, drugs, and critically, lipid emulsion within arm's reach.
So think of this as your safety protocol, and it has to become automatic. First, you must have a working IV before your needle even thinks about touching the skin. Second, full ASA monitors on and running. Third, that epinephrine test dose is crucial. You're looking for that tall peak T wave on the EKG that screams you're in a vessel. And last, always confirm the block actually works before they cut.
Now, when it's time to send them home, your job isn't done. And the number one thing you're looking for, the mandatory part, is that the child has regained some motor function. A numb arm is okay. A completely limp, paralyzed arm is an injury risk. Parents have to be taught how to protect that limb and when to start giving pain meds at home.
And that's really what it all boils down to, isn't it? When you truly understand the why, the unique anatomy, physiology, and pharmacology of kids, you stop just doing a procedure. You start mastering the art and science of pediatric regional anesthesia, and that means you're providing safer, better care for your patients.
So I'll just leave you with that question to think about before you walk into your next pediatric case. Thanks for your time.